So today I'll cover the criticality of radiation oncology in global cancer care. My disclosures. So several years ago, 2015, Lancet Oncology published an issue in their journal on the global cancer problem, specifically as it relates to radiation oncology, with an eye towards what the future might hold in 2030, 2035. So I'll review that. Also important to understand that radiation oncology is one of the disciplines that contributes to cancer care. And as we try to solve problems, we have to think not just of our own modalities, but also enlist the support and enthusiasm of our care partners as we negotiate expanding care across the globe with medical oncologists and surgical oncologists and other disciplines that support our care. There are unique challenges in radiation oncology. We'll cover the future needs assessment, the gaps in training and education, some technical solutions, how we might invest and finance these expansions, and then our story supporting a small clinic in Guatemala. So from that Lancet oncology issue, we see that there are roughly 14 million new cases of cancer diagnosed worldwide and 8.2 million deaths in 2012. But if you break it down by the Human Development Index, the diagnoses in high and very high countries represent a different collection of malignancies, with the top 5 cancers being breast, prostate, lung, colorectal, and stomach. But in low Human Development Index, we see that breast and cervix cancer dominate cancers of women. Also, the number of deaths to the number of new diagnosed cases in high development countries is roughly 0.5, whereas 0.75 in the lower Human Development Index countries. Over the next 10, 20 years, we expect to see the population of the world grow, with the largest growth in medium and low income countries. The incidence of cancer is projected to grow as well, from 14.1 million cases in 2012 to nearly 25 million cases in 2030, with the largest proportion of these growth of new cancers in medium and low income countries. The distribution of these cancers, as I pointed out, is very different across the globe, with prostate and breast cancer, illustrated here in green and pink, being dominant in North America, South America, and Australia. But cervix cancer is very prominent in sub-Saharan Africa and parts of Asia. And when we consider how we will meet the needs of these growing risks of cancer in the world, we need to understand how radiotherapy is used for these different malignancies. And we see that the radiotherapy utilization rate in a nominal sense is very frequent in cancers of the breast, cervix, colorectal, head and neck, lung, etc. And understanding the number of fractions that might be needed to treat these patients and the impact of radiotherapy on the local control and overall survival will help us understand the impact that availability of radiotherapy will have to patients in these countries. Now, unfortunately, the coverage of radiotherapy services across the globe is very uneven, with the development countries, the United States, and parts of Europe having a very high amount of radiotherapy facilities relative to the incidence of cancers. But we see a rather dearth of radiotherapy facilities in sub-Saharan Africa, Asia, and Southeast Asia. And so to meet the needs, we will have to make investments in the future, including both capital investments, radiotherapy departments, megavoltage machines, and scanners. But more importantly, we need to understand that we need to close the gap on the professionals that will be providing these cares. They're particularly in low, middle income and low income countries where there is very few centers to start with. There are very few mentors and educators and caregivers that can pass this knowledge to the future needs. And so we need to understand there has to be a more efficient means, a better way to deliver education and training in these low and middle income countries. Now, what will be the return on investment after we make these capital purchases and train these caregivers in cancer care, specifically in radiation oncology? And this is a very important graph that we see the benefits to making these investments calculated two different ways. The human capital benefit in the bar graph shows what the income of a survivor might contribute to society after having been treated. But more importantly might be the full income benefits, which refer to not just the life saved and the income saved, but also remember, if a woman dies of cervical cancer or breast cancer, that impacts not just her life, but the life of the family that will also be without a mother or a partner. And so the full income benefit really is a better idea of the loss of someone who dies from cancer. Looking at the costs, there are two different ways to calculate this. There's the nominal model, which assumes 4 treatments per machine per day, an operating time of 12 hours, and regular purchase power in the radiotherapy marketplace. Whereas an efficient model may look at increasing from 4 to 5 treatments per hour, a work day of 16 hours rather than 12, and the opportunity to have bulk purchase discounts from industry. No matter how you look at it, the benefits outweigh the investment, whether it be looking at the human capital or the full income. And with an efficient model, this return on investment is even greater. So how will we meet the needs of the workforce? One is to consider novel approaches to education. One of the ways to do that is to shorten the time that it takes from entering a program to graduation. And so if you look here, increasing the training from, or decreasing the training from 5 years to 4 years to 3 years will accelerate the number of candidates available to offer care. Now, there are obviously problems that might be created by shortening the overall duration of training, but we have to meet those deficits by more creative means of training and education. The workforce includes physicians, physicists, therapists, dosimetrists, and nurses. The traditional model in the United States is a student will graduate from his university or her university, go to graduate school for a physicist or medical school for a physician. They'll complete a residency and sometimes perhaps a fellowship. This can be 12 to 16 years, which is a very long time and a lot of investment to make for that type of training. Fortunately, there are organizations in the world like the IAEA that are offering online courses and remote learning to train both physicians, but also some of the support staff to meet the needs across the world. I Treat Safely, established by my colleague, Dr. Mutek, who was a former Washington University physicist, again offers online courses to train therapists and dosimetrists on how to treat patients. the global university that Dr. Noir mentioned, the rayons contra cancer, and even industry has entered the foray by having remote learning options. So industry is an important partner, and they have responded by developing capital equipment that is more reliable and requires less maintenance and service. An approachable user interface, which is important as we have these training gaps. Low energy consumption is important as well. Improved workflow efficiency to be able to get to that efficient model where we can treat more patients in an hour's time. They took into consideration the facility and space considerations, such as needing shielding for the rooms that hold radiotherapy equipment. And of course, the machines have to be affordable. At the same time, there's IT related issues, software that is using auto contouring to again facilitate the knowledge gap that might occur and require a more efficient planning approach, contouring organs at risk and target volumes. Knowledge-based planning, another approach to creating optimal radiation plans using artificial intelligence. In the future, we'll have automatic verification of image setup fields. And something else we're working on at Washington University is decreasing the time that it takes to commission a machine from installation to its first use. So the modern radiation Linacs, we see a low profile, low power consumption, and a much easy user interface. We see Varian and Elekta, the two dominant vendors in radiation oncology, have developed radiation therapy devices that are much more available to lower and middle income countries. And then we see other companies creating combined CT scanners and therapy units that will make it more available to other countries. So Washington University, through our public health and global health departments, reached out to a center in Guatemala City, the Liga Incan Medical Center, and two of our faculty, Dr. Hiram Guy and Jose Garcia, visited the center in Guatemala City and did a needs assessment. They found a clinic with two defunct cobalt units, two linear accelerators, an HDR afterloader, partially functioning simulator, a shared diagnostic therapy CT scanner, but most importantly, a waiting list for care of up to 6 months. In Guatemala, there are just 4 radiotherapy centers, and Liga Incan is the only public hospital available. All these centers are located in Guatemala City. So in 2016, when we visited, we saw 2 linear accelerators, a brachytherapy system, and a cobalt system that was no longer functional. And predominant approach to treating patients was using old 2-dimensional radiation therapy planning. What we did notice is that they had a stable infrastructure with power and service, great physicians and other professionals in the healthcare system, strong management at the leadership level, the president of the hospital, and established collaborations with our university. Guatemala City is located in Central America and has a high incidence of cervical cancer, breast cancer, and prostate cancer. So we reached out to the United States Agency for International Development to help provide support to deliver improved care in Guatemala City. USAID grant was going to cover part of the cost of the linear accelerator and its supporting software on the order of about $1.1 million. Liga Incan provided the room remodeling and, of course, the staff and faculty to deliver care. Washington University provided travel construction oversight, employees, materials, and management. And Varian provided in-kind donation, part of the Linac and the software. And the Nuclear Safety Agency addressed the issue of cobalt removal. The technology we had transitioned from this cobalt unit, which was no longer functional, to now a modern Linac with a very straightforward user interface and very efficient in its treatment delivery. It was delivered in, we applied for the grant in 2017, even before the equipment had been FDA approved. We were planning to move from two-dimensional radiation therapy to intensity modulated radiation therapy, which required training of the physicists and dosimetrists. So we brought them to the United States to observe our practice in St. Louis. One of the advantages of this machine was a small footprint, so it could fit in the existing cobalt space. It has internal primary shielding, which required less renovation of the space, 40% less energy consumption than a typical linear accelerator, internal service diagnostics, which lessened the need for service and maintenance, and designed to use less staff and have a higher throughput. One of the concerns often raised about delivering new radiotherapy equipment to low and middle income countries is the power consumption. And I would maintain that if your modern medical system can support diagnostics such as an MRI scanner or a CT scanner, it can support some of these new linear accelerators that are designed to have less power consumption. So this should be less of a barrier as we go forward. Other important contributions to improving access is using artificial intelligence and other IT communications to enhance cancer care. Auto contouring, as I mentioned earlier, can help prepare plans for patients who are in centers where the physicians or staff may not have the time nor the higher level training necessary to create these complex radiation plans. Likewise, knowledge-based planning, automatic planning can be used to help create radiation plans that are much more highly conformal than those of 3D radiation planning. We are working with the Liga ANCAN Center in Guatemala City now to see if we can't translate rapid plan models, radiation plan models from our center to their patient population, to see if using rapid plan or artificial intelligence to create radiation plans might make this model a much more efficient delivery system for patients outside of our center in St. Louis. Likewise, Dr. Baoju Sun, one of our physicists, is developing means to do a much more rapid acceptance testing and commissioning using the existing portal imaging devices built into modern day linear accelerators to change the time that it takes to commission a machine from months to just a few days, which will also improve quality assurance during the actual day-to-day operations in a radiotherapy clinic. Finally, to speak about ASTRO's efforts in international and global cancer care. Before 2013, an international educational subcommittee was established to advance radiation oncology beyond our national borders. It was revamped in 2013, and in 2014, a workshop in San Francisco covered safe implementation of advanced radiotherapy technologies and techniques, and this is currently archived on ASTRO's website. But in 2021, this year, the International Education Subcommittee was elevated to full committee status, identifying its first chair, Dr. May Abdelwahab from the IAEA, and Dr. Serby Grover from the University of Pennsylvania, who will be the vice chair. The relationship with the IAEA has been strengthened, and ASTRO has contributed support for an upcoming update to the Lancet 2015 Commission covering radiotherapy and theranostics. We also invest in the Association of Residents in Radiation Oncology to have trainees receive funding to do international experiences. To date, 24 individuals have participated in this, and we look forward to future collaborations with ARRO and Global Health. So to summarize, cancer is increasing incidence throughout the world. Radiotherapy is a critical component of multidisciplinary care, and radiotherapy improves quantity and quality of life. Capital investments in technology have a positive return on investment, and expanding the workforce takes creative education and training models, and artificial intelligence and remote communication, I believe, can facilitate quality care delivery to distant parts of the world. I want to acknowledge my collaborators at Washington University and Guatemala, and colleagues from ASTRO and AAPM who helped prepare this talk. Thank you.